we are going to be today we are going to be talking about drugs that affect the central nervous system, drugs that affect the musculoskeletal and the central nervous system. But we are going to be starting with drugs that actually affect the nervous system, basically. um I will advise us to kindly jot, because most of the a lot of things that I'm going to be saying here might not be on this projection, but if you can jot, it will be very, very beneficial. So we're going to be starting with the neurological drugs first. The neurological drugs first. So one of the first classes that we're going to be considering is anticonvulsant. Anticonvulsant. Please pay attention, because these drugs are one of the most tested drugs. One of the example of anticonvulsant that we're going to be talking about is phenytoin. Phenytoin, of course, we know that the indication is usually seizure and epilepsy. And remember, this class is a fast review of whatever it is that we already know. So we might not be touching on so many on the details, but this is just to help you like brush through what you have done, and also so that you can go ahead and use the practice questions to seal what you understand about the whole thing. So phenytoin indication is seizure and epilepsy, and it is usually used for a long time. It's a long time therapy for seizure and epilepsy, and it lasts longer in the body as well, and patient can get toxicity. So therefore they need to check their therapeutic level every time. So when you are talking about your nursing consideration, very important, check therapeutic level. And the therapeutic level is, the therapeutic level ranges between 10 and 20, right? 10 to 20. Above 20, you need to notify the doctor, or the person that is taking care of the patient. You need to notify the person. There's usually routine blood tests just to check for those therapeutic level as well. And you need to give the medication same time in a day. The last time we had class as well, Daily was talking about, when we talked about route of administration and all of that, Daily talked about some drugs that you should be given at a particular time of the day, you know like when he was talking about drug use in thyroid thyroid disorders. You need to take them at the same time. Same thing as phenytoin. Try as much as possible to encourage patients to take it at the same time of the day. So there could be early signs of toxicity, which include ataxia, that is unstable gait, and hand tremor and slow speech. Those are the early warning signs of phenytoin toxicity. And the adverse effects will include suicidal ideation, skin rash and Steven Johnson syndrome. Those are adverse effects that you might see in phenytoin. And there are some other expected effects. If you remember, when we talked about mechanism of action, we talked about what's it called, the kind of action that drugs might give, which can be agonist and antagonist, or idiosyncrasies. But this expected side effects include bradycardia or hypotension, gingivitis, and hyperplasia. Gingival hyperplasia. The teeth, the gum might become red and all of that. Then there will be gum bleeding. So any patient that is taking phenytoin, you know that we want to tell the patient to use soft brush or use foam to brush their teeth or something like that. They should use soft brush, and they should stop. They should they shouldn't stop abruptly, and they can take some folic acid and vitamin D to enhance all these so that's phenytoin for you. And other examples include carbamazepine, valproic acid, and levotiracetam. The same indication, um the same indication really, and mode of action stabilizes the neuronal membrane by affecting ion channels. Like this, they affect the sodium and calcium ion channels. So that's where they act. That's where they that's how their mode of action is generally. But we've talked about the indication, which is epilepsy, seizure disorder, and all of that. And we've talked about the side effects. We've really talked about the side effect as well. All right, so and those are the examples of anticonvulsants really that we want to talk about this evening. We are talking about neurological drugs. If you are just joining us, so we quickly move to cholinergics. We have one of the most common drugs or examples in of cholinergics are neostigmine and pyridostigmine. These two examples are very common. Usually, the indication is myasthenia gravis, and we all know that we all know what myasthenia gravis is. And one of the signs and symptoms that you see there in myasthenia gravis, they are usually dry. They cannot move. They cannot tear. They can't cry and all of that. They are dry up. So what cholinergic does do is that it adds fluid to them. It make them produce more fluid. So somebody that is dry before becomes more let's say become wet. Let's put it that way. So the side effect of cholinergics includes um, they cannot they become constipated because um, sorry, no, not constipated. There is diarrhea. Remember that in cholinergic, if the cholinergics is what cholinergics does is it add water, that is, it make people wet. So that will be what's it called, that will be diarrhea. There will be they can have a lot of saliva. These are the side effects. Just remember, anything wet, any symptoms that look wet in the body, there will be a lot of tearing, there will be a lot of sweating, there will be a lot of there could be a lot of urine as well. There could be pupillar constriction as well. So these are there will be a lot of salivation and diaphoresis and diarrhea. So these are the side effects of cholinergics. These are the side effects of cholinergics, and the most example, uh, the common examples are neostigmine and pyridostigmine. So quickly we move to anticholinergics. Just the opposite. Just the opposite. It dry up secretions. A very good and common example is atropine used in what's it called bradycardia. So that's a good example. So quickly, we'll move to migraine drugs used in migraine. One of the most common example is somatotriptan. Somatotriptan, SUMATRIPTAN. Somatotriptan. What it does, it just causes vasoconstriction in the brain. It causes vasoconstriction, and the indication, just like what the name suggests, is migraine. The indication is migraine, and the contraindication include coronary artery diseases and uncontrolled hypertension as well. So the advantage of this pre-recorded class is that you can stop it and listen again and make your notes. You can jot and make your notes. So which I consider as a good a good one, to be honest with you. Let me just look for um if let me look for that and put it on the screen so that people will be seeing. Yeah. So we've talked about cholinergic. I mean, we've talked about anticholinergics. Atropine was one of the most example that we talked about there. Scopolamine and ipratropium. Ipratropium. That was one of the examples that we talked about there. So uh, we have just talked about drug use in migraine, which is somatotriptan, is a very good example that we talked about. So nursing consideration is you need to teach the patient to report the signs of angina. It is very important. Remember, the contraindication is coronary artery disease and control and uncontrolled hypertension. So you need to teach the patient sign of angina in case if there is any chest pain or anything, they need to escalate quickly. Another thing is you must screen patients for uncontrolled hypertension before you start giving them. So another example of the drug used in migraine is ergotamine. Ergotamine. So indication, of course, migraine, and we need to teach the patient to take one tablet at every onset of headache. This is more like a PRN thing. So next we move to Parkinson drugs. I don't know if we have it on this slide, but Parkinson drugs. We don't have it on this slide, but just let's listen very well. Let's listen attentively. You can make some jottings. You can make some jottings, please. Mm. All right. So one of the most common example of a Parkinson drug is carbidopa and levodopa. Carbidopa and levodopa. So what carbidopa does is it conserve more dopamine, and what levodopa means, what it does is it leaves more dopamine in the brain. Just simple like that. Carbidopa, levodopa. We know that, when you talk about the pathophysiology of Parkinson, it's all related to the dopamine. So that is for another day when we get to Parkinson in med surg. But today we are just talking about carbidopa and levodopa as a drug used in Parkinson. And remember, this class is just a quick review of what you have known. Use practice question test to evaluate what your knowledge is. All right, so carbidopa and levodopa. Carbidopa, it conserves more dopamine in the brain, and levodopa leaves more dopamine in the brain. Basically, the adverse effect of carbidopa and levodopa is hallucination, and orthostatic hypotension. Those are the side effects. And of course, we know that indication is Parkinson. So long time use of these two drugs can lead to toxicity. It can definitely lead to toxicity. And the signs of carbidopa levodopa toxicity includes dyskinesia, that is involuntary movement, that could be face twitching as well, face twitching, tongue out, and that could be face grooming as well. So if you see any of these signs of toxicity, the first thing that you do is to notify, the physician, or the person that is taking care of the health caregiver. No, like the doctor. So the doctor. All right. So the teaching we can give is like, we can tell them that it has a low onset. These are nursing consideration. Teach them that it has a low onset of action, and teach them to position slowly, because like we said, the side effect is orthostatic hypotension. So they need to rise slowly and all of that when they are standing up from their sleep and all of that, or when they are standing up to get something. And they need to have high protein meal as well, and they should never stop the drugs abruptly. Of course, this that one is more like a general general cheat sheet for when we were writing theory back then in nursing council. But all right. So quickly we move to I think we've done anticholinergics. Yeah, we done anticholinergics, where we talked about atropine, and we talked about benzotropine. I think we've done yeah, we have done anticholinergics. So quickly we move. Okay, in case if nobody was here, but anticholinergics example, one of the example is atropine and benzotropine. And what they do is they are just anti-secretions. They just dry up people, and the indication include Parkinson and tremor. Parkinson and tremor, bradykinesia and all of that. So side effects include tachycardia, tachycardia, and contraindication is when the patient is already dehydrated. You don't need to use it. In bowel obstruction or severe diarrhea, you don't, because they will dry up the patient more. In glaucoma as well, you don't need to use them as well. In BPH, those are the contraindications really for anticholinergics, and the most common example is atropine. So quickly we'll talk about almost diuretics, osmotic diuretic, but that's another example in cardiovascular this thing. But because of monitor, we just need to talk about osmotic diuretic because it is usually used in one of the indication is brain swelling, you know, in case of any accident and all of that. So, and sometimes it is also indicated in meningitis and in glaucoma as well. So that's why we're just talking about monitor here under drugs used in neurological neurological system. All right, so one of the side effects of mannitol is heart failure and edema, pulmonary edema as well. Because it drains all the fluid from the brain and brings it down to the body. So somebody from the brain, it brings all the fluid and dump it in the body, and usually, the lungs suffer in the process. So somebody can get pulmonary edema from the use of mannitol. All right, so one of the most important nursing consideration in monitor usage is the nurse or the person that is administering the drug must use a filtered giving set. You must use a filtered giving set. At that point, you must not forget to use a filtered giving set because the drug it's as if it's crystallized. It's not crystallized, but it's, what I'm saying. All right, so we'll quickly go to neuromuscular blocking agent. I think we have some of them here. Also relaxant, neuromuscular, yeah, neuromuscular blockers. Yeah. So we have some of them here. And one of the common example, one of the most important and common example is the sorry, what is it called? Let me check. Succinylcholine, yeah, succinylcholine. It's very, 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 very important. If you forget anything, don't forget succinylcholine. So succinylcholine, although neuromuscular blockers are classified into two. We have the depolarizing and the non-depolarizing one. Non-depolarizing neuromuscular blockers. An example of depolarizing neuromuscular blocker is succinylcholine. Is actually short acting. It's a short acting drug, and mode of action it's that it just mimic acetylcholine and causes sustained depolarization of muscle fiber. It is used during anesthesia. It is commonly mostly used during anesthesia to relax the muscle so that they can intubate the patient. So succinylcholine is a short acting neuromuscular blocker, and one of the indication is intubation and muscle relaxation. So, and the side effect, this drug is very important because of this side effect that we want to talk about, which is malignant hyperthermia. Hyperthermia, it is very, very important because of malignant hyperthermia. So one of your assignments for tonight is go and check what is malignant hyperthermia. What is malignant hyperthermia, and what is the drug of choice to reverse, and what is the drug of choice used in malignant hyperthermia? You check that out quickly, please. So another class of neuromuscular blockers include the non depolarizing neuromuscular blockers. These ones are a little bit long acting. They are long acting, and what they do is they just compete with the com so what they do is they just block acetylcholine in the neuromuscular junction, thereby causing relaxation of the muscles. So an example is rocuronium pancuronium, vencuronium. These are drugs. This Most of these drugs end in rhonium. So it is very very easy to remember that, oh, this is a long acting drug and long acting muscle relaxant. So we quickly move to um what other one is remaining that we have not talked about. Or antipsychotics. Yeah, let's quickly talk about anti drug use in psychiatry. Sorry, let's talk about drug use in psychiatry generally. So, no, one of the first one we are going to be talking about is anxiolytics, but we need to be fast. Just pause the video, jot down, and come back. Right? um Anxiolytics. So we have the benzodiazepines like midazolam, like aprazolam, like diazepam, like that. They all end in zepam. Most of them, they all end in zepam. So it is very very easy to remember. All right. So, and midazolam, it's a fast acting and short acting what's it called, benzodiazepam, right? And it's usually sometimes addictive. All right. So indication includes indication indication include seizure, anxiety, and alcohol withdrawal. Those are the indication, and the side effects include sedation, low heart rate, low BP, low respiration rate, low sleepiness. Everything is slow with benzodiazepines. Everything is slow. Everything is just slow. Sedation, heart rate low, blood pressure low, respiratory low, airway, sleepiness. So what you teach the patient is to take you teach the patient to take the drug at bedtime. You should take the drug at bedtime, and they should not skip their dose. Those are the nursing consideration, and they should never stop the drug abruptly, and no alcohol and wine when you're using this drug, because you become more slow. And don't use the drug when you know that you are going to be operating machine. So, like I said, this class they are just they are crash classes. Like, they are just crash classes for us to remember all those things that we have learned. And one of the antidotes for that benzodiazepine is flumaxylene. Daily already talked about this last week. You already talked about this. So antidote for benzodiazepine is flumaxylene. All right, so we'll talk about barbiturates quickly. So one of the most important example there is phenobarbital or phenobarbital. It's just a long acting anxiolytics, and it also takes long to get out of the body. So there's also a high risk for toxicity in this kind of when one is on these drugs. So another one is buspirone. Buspirone is another one, but this does not cause any sedative effect, and it does not cause any depressive effect as well. All right. So uh, which other one on the neurological drugs? The last one on neurological drugs should be the antidepressants. Yeah, antidepressants. It's very important. We must talk about no. There's antidepressant and antipsychotic drugs. Oh my god. There's still two of these drugs. Okay, let's quickly talk about them so that we can move on to another thing. So antidepressant, um okay, let's quickly just go to the classes of antidepressants. We have the SSRIs, we have the MAO inhibitors, and we have the SNRIs, and we have the TCAs. So I know you already know the full meaning of all of this. So um, let's start with SSRIs. selective serotonin reuptake inhibitors SSRIs. The examples are include sertraline, escitalopram, citalopram, fluoxetine, paracet. I forgot the name of that. I forgot the name. Please kindly look for more example under SSRIs. Centraline, citalopram, fluoxetine. Fluoxetine is very very important. At least we can't just forget that. We can't forget centraline. We can't forget fluoxetine. We can't forget escitalopram. We can't forget citalopram. And why we cannot forget fluoxetine is that that's also the only drug that they use in bulimia nervosa. Fluoxetine and bulimia nervosa they are just 5 and 6. Don't forget that. So one of the most indication for um, SSRIs SSRIs are depression, anxiety, and PTSD. The side effects include weight gain, sexual dysfunction as well, and insomnia. Yeah, insomnia. Very, very important. Insomnia. The key point to remember is always remember that with selective serotonin reuptake inhibitors, there's always suicidal risk. There's increased suicidal risk. There's slow onset of drugs, and there is also the person can be sweaty, the person can be hot, and the person can might be having signs of fever. There could be rigidity of the muscle as well, and the person might be restless, and there is tachycardia in SSRIs. So we go to SNRIs, and so one of the most important the important drugs there include let me see, trying to remember. Yeah, venlafaxine. Yes, there's venlafaxine and there is duloxetine. Duloxetine, don't forget, it's very very important too. So um serotonin non-epinephrine reuptake inhibitors, example include venlafaxine, duloxetine, and the indication, of course, depression, and there is also fibromyalgia, which is a very terrible pain. Um, so those are the example, and most of the side effects is also more like the selective serotonin reuptake inhibitor as well. So TCAs, TCAs example include example of TCAs. They are those ones that are aminotryptyline and then imipramine. Those two examples, they are very very important. So tricyclic antidepressant. Example is aminotryptyline and imipramine. Indication is depression and anxiety, and side effects include tachycardia. This is common with both SSRI as well. Cardiac arrest is also common, and there is also anticholinergic effect. That is the person the person is dry. Remember our cholinergic drugs. The person will become dry. Um, um, there's also sexual dysfunction as well. So from there we move to MAO inhibitors. Example of MAO inhibitor are selegiline, isocarbazacid, and phenicin phenicin. So the key point here is that there is massive hypertensive crisis, and there is also point to note is that we should tell the patient to avoid anything that contain tyramine, anything, all those red meat, wine, cheese, and all of that. They need to be, stopped as well. Okay, and other things to do is they need to avoid other um other antidepressant drugs. It's very very important because of drug interaction and all of that. So they need to stop other depression depre- depressants. All right, so that's all about monoamine oxidase inhibitor. So MAO inhibitors were done. Then the last bit will include atypical antidepressants like trazodone and bupropion. So bupropion. The pronunciation is kind of tearing my mouth apart as well. So just just go just look out that atypical antidepressant so that we can call the class a day. All right, no, we have not talked about antipsychotic alloperidol, which is one of the most important drugs there, um, and and chlorpromazine. Yeah, chlorpromazine, that's very important. CPZ is also very important. So look up antidepressant and just and that brings the end of drug use in drug use in neurological um system basically. All right, so I'll send this PDF too as well back to the class. I mean, so that we can all go through and see. All right, thank you.